welcome to the Psych Guys. This is Dr. Logan Noone. I'm a psych resident. I'm with my colleague and great friend, Dr. Jun Chun, also a psych resident.
Hello, everybody. Welcome back.
Yeah. So, second episode of us doing as a YouTube series. We're YouTubers now. So if you're listening on the audio sphere, go check us out on, I guess, YouTube, Instagram.
Hopefully, the videos will have no issues and we will actually be able to upload these.
Yeah.
So hopefully the clips will be up, and if they are, please do go ahead and check that out.
Yeah, I don't have any video skills, so we'll see.
Neither do I.
See how this
Starting
goes.
from the bottom.
All right, so we're talking about an interesting case that I had. It's about psychogenic non-epileptic seizures. Have you ever encountered this, or what is your? Have you seen this?
Yes. I have. Yeah, I'm gonna say that I've seen it, but it's always complicated because it's one of those diagnoses by exclusion, right?
Right.
You just kind of rule everything else out, and if nothing else makes sense, you just kind of go with, oh, this is a psychogenic seizure.
Right. And it's always, I feel like explaining that to non-medical people is very, very weird, right? Because it's what we mean by diagnosis of exclusion is there's no test to specifically say, oh, it's this. You kind of have to test for everything else, and then you say, well, it's nothing that we've come across, is it? So we think it's this. So a lot of things in medicine are uncertain in some regard.
Right. Logan, is it fair to say that if a patient looks like they're having a seizure and neurology comes and they do their EEG, they do their fancy test, and if they say, okay, by the waveforms on the EEG, it is not consistent with a focal seizure, or I'm not even sure what the term is. What's the term that they use? I'm blanking here, Logan.
Epileptic form of seizure.
Yes.
Certain
epileptic
brain
form
waves
seizure
that produce involuntary like movements.
Right. So if it doesn't look like that, we can say that this is a psychogenic seizure.
Sort of. There's long-term EEGs, and I'll get into that. And like sometimes, they're 24 hours in nature. Sometimes there's 48 hours in nature. I've even seen previous cases of 7 days in nature where they videotaped. But I'll get into all of that. Sit back and relax, and we'll have an educational discussion today about psychogenic non-epileptic seizures. But similar to how we learn in
Hold on, Logan. Before you continue, what is it called? Psychogenic
non-epileptic seizures, PNES.
And how do you pronounce PNES? Penis. I just wanted to say that.
Zing. I was like, wait. Am I not saying it right?
I have the maturity of a third grader.
Nice. Okay, with that wonderful third grade joke to start this off. So this was a case that, obviously I'm not going to give the exact details for HIPAA reasons, but let's just kind of go over how I kind of got involved and what it kind of looked like. This was a young female who brought in for kind of wild-like movements, and by wild I mean like thrashing her entire body, moving all around. They tried to get potentially a CT image of her head, which was fairly normal. Then they proceeded on to an MRI, and this person couldn't even complete an MRI because they had another really significant seizure. At that time, they believed it was like really kind of a traditional seizure in some nature, because a lot of times these psychogenic non-epileptic seizures can mimic exact seizures. But there was a few things that was different about this. Now, when me and you or other people in the hospital kind of setting encounter someone having a seizure, they get benzos. So this person was getting tons of benzodiazepines and still having a lot of these kind of movement-like episodes. Now that doesn't necessarily mean it's psychogenic non-epileptic seizures, but maybe it was some intractable form of seizures. So you kind of referred to, how is the kind of diagnosis made? So eventually they did get kind of a further brain imaging showing that there was no significant cancer. Of note, this actual person did have actually some autoimmune disease, so multiple sclerosis. So maybe that did factor in. It's kind of impossible to say if that factored into this person's movement-like episodes, but this person would have significant movement episodes where they would thrash their entire body, sometimes scream out throughout these episodes, become extremely tachycardic, as high as like 200 beats per minute, really hyperventilate pretty significantly, have their eyes closed through a lot of these endeavors, speak in full sentences at times. So kind of weird, untraditional forms of seizure at that time.
Yeah, the yelling certainly doesn't make me think of a traditional seizure.
Right. And so these are when the neurologist came on board, kind of immediately their spidey senses were going up, like, oh, this might be a little untraditional. But either way, us physicians are taught how to rule out, really scary diagnosis. So this person received electroencephalogram, an EEG. This is I always like to describe it as like the Medusa thing, right? Where they connect electrodes all over someone's head and measure brainwaves. I remember sitting in medical school with Dr. Tony Lee, who I interviewed on my personal podcast. Quick segue and shout out to my personal podcast. Talk Mental Health with Dr. Logan Noone. And he's a neurologist and epileptologist, so someone who did a fellowship in epilepsy, who would study these brainwaves that go by. And it just looks like, how would you describe this EEG when you look at it?
I was going to say, I look at that and I never know what's happening.
No idea.
It just looks to me like just random waves just going up and down, up and down, up and down. And yeah, I just kind of look at that and I just say, I'm not a neurologist, and I walk out the room.
Right. It looks like witchcraft. It really does.
It's intimidating.
Yes. And I remember actually asking Dr. Tony Lee, I was like, how do you interpret this? And he almost said, you have to look at it like it's a sheet of music. And like look at all the lines kind of in nature. And after he sent, I literally spent hundreds, if not thousands of hours looking at these various EEG kind of reads. And that's how you end up being able to recognize, oh, okay, this is actually epileptic in nature. So one of your first questions that you asked, it's like, well, these EEGs seem to range sometimes for very short, 15, maybe 30 minutes in nature, or a full 24-hour EEG monitoring. Sometimes there's 48 hours. Sometimes there's even, much longer than that, where there's like at-home EEG kind of wearable devices that someone will wear around for like a full week at a time.
Before you go on, Logan, you said epigenic?
Yeah.
Is it fair to say that that is originating from an abnormal waveform from your brain?
Right. To produce kind of odd, uncontrollable movements, like traditional.
And that is how we understand traditional seizures to be. It's an area of your brain that's producing abnormal wave activities that can be measured on this EEG that leads to what we physically see as the symptoms of a seizure disorder.
Right. So, this individual had gone through actually multiple EEGs in the past and then an EEG in this hospital stay. This one was a full 24 hours, maybe it was 48 hours, doesn't really matter. But no epileptic form. No epileptic wave forms were found during that video. So you also get a video kind of recording and also the brainwave recording of that time. So these things give more hint that this is, possibly a psychogenic neuroleptic seizure in nature. But it's kind of impossible to say, right? Like maybe there was epilepsy that is happening when we just don't have the electrodes on. What was kind of interesting is there was a movement episode when the electrodes were on, connected to them.
For this lady?
For this person, yes.
Okay.
So that was also kind of further evidence like, this is actually probably not epileptic in nature because they had kind of a movement episode.
Without an associated waveform on the EEG, right? That's what you're saying?
Right.
Okay.
And, this is an extremely challenging diagnosis to make. And I say that because sometimes these movements can mimic exactly what real kind of traditional seizure look like. So I don't know if everyone's seen a seizure, but, kind of like weird, shaky movements, right? But there are a few distinguishing features that traditional seizures, for the most part, don't have. We kind of touched on them a little bit, like speaking in full sentences or like phrases is actually something that you don't see in traditional seizures.
Right, because typically they remain silent, right? If I'm not mistaken.
Right. Another distinguishing feature that I found very interesting that I just learned is most epileptic seizures in nature, the person has their eyes open throughout that seizure. So it's actually more indicative of maybe a psychogenic epileptic seizure, psychogenic non-epileptic seizure that is closed eyes in nature. Some of the other distinguishing features, there could be lack of drowsiness after an episode. We typically see like a post-ictal state after a normal epileptic seizure. Sometimes, some of these psychogenic non-epileptic seizures, They see extremely wild thrashing, side-to-side head movements, like I said, shouting or stuttering phrases, closing of the mouth and the eyes, resisting opening during the seizure. So, like if ever you've tried to open someone's eyes passively, like open someone's eyelids passively, they're like clenching down throughout that seizure or non-epileptic seizure. Sorry, I keep going back. This is kind of, I guess we could use the acronym of PNES, PNES, or say the whole phrase. I actually listened to this really great lecture on this that I would like to refer all the listeners to today. If you go on YouTube and just type in psychogenic nonepileptic seizures, the Epilepsy Foundation gave this really great 47-minute talk. I wish I had the guy's name in front of me. I wonder if it's in the, let me look. Is it? I don't know. But this guy was a triple boarded physician in psychiatry.
My goodness.
I know. He had way too much time on his hands. Psychiatry, neurology, and epilepsy. That was his triple certification. So he really, I found, was to be an expert of this. Oh, Andreas Kanner. He's an MD who talks about psychogenic non-epileptic seizures. This is a great 47-minute talk. And if you like any of my 11 minutes thus far, go check that out because he knows way more about this than I do. But this was really an interesting case for me. Because it got me really learning a lot about what this really is. Now, this is actually a version of conversion disorder. So conversion disorder is when we have kind of a mental stimuli that then is manifested into something physiologic in nature. What do you know about conversion disorder?
My understanding is that it's a physical symptom due to a significant stressor. So you can, for example, lose motion of your arm temporarily. And I'm just throwing a wild example out there. That sounds very serious, but it has been known to happen before.
Right.
In response to a stressor such as, I don't know, let's just say you lost a cousin to a sudden motor vehicle accident.
Right.
And just that emotional stress is enough to manifest in a physical sense, and sometimes even in a way as scary as you possibly not being able to move your arm for a little bit.
Right. Even, or like episodes of like mutism, which is maybe like a version of catatonia, but is it catatonia or is it a conversion disorder? I've seen actually that exact case after it was a recent grief where one of their loved ones passed away and they just like stopped talking for like 3 months.
Right.
Kind of like,
so a lot of things can happen.
Yeah. So this psychogenic non-epileptic seizures, they think, is a version of conversion disorder. It's actually fairly common. They estimate that between 2 to 33 people per 100,000 people have psychogenic non-epileptic seizures. It is actually more women than men.
Okay.
At the end of the day, more women than men. And they mostly actually see it in younger individuals below the age of 35. And it's actually also more prevalent in people with intellectual disabilities. They theorize that maybe that person can't put their feelings into actual words. And so then they act them out in
That's
in
very
motions.
interesting. Very interesting. So just to kind of summarize what you said, psychogenic non-epileptic seizure is something that is induced by an external stressor.
That it's unfair to really say that. We don't exactly know what's causing it. A lot of these individuals, though, at the end of the day, and I don't have the exact numbers in front of me because measuring this is very, very challenging. And it's not like there are also seizures and non-epileptic seizures are mutually exclusive. Sometimes people do have a history of epilepsy, but then they'll have these movement episodes that are non-epileptic in nature too. Okay, and also, how do you perfectly measure people who have history of trauma or people who have history of anxiety? We try to measure these things for a living, but we know that the sensitivities of our tests, and when we ask patients, hey, do you have any trauma history? Of course, we're not always going to pick that up 100% of the times. But a lot of times, these individuals do have a history of mood disorders, post-traumatic stress disorders, anxiety, sexual, physical, emotional abuse, maybe personality disorders. It's very, very common. So the best way to treat it is perhaps maybe the underlying cause, offering some therapy for those various mental health conditions. There have been some research showing that cognitive behavioral therapy can help. It's not perfect, though. perhaps some of the medications that we use for post-traumatic stress disorder, like SSRIs, SNRIs, kind of the classic treatment that we see can help, but it's not perfect. What would you want to learn more about psychogenic non-epileptic seizures?
I guess the biggest question would be what we can do for patients that's given this kind of diagnoses, because the cases I've been involved in have always ended in the psychiatry service kind of commenting outpatient follow-up for therapy. There's nothing that we can do besides treat their external stressors, to treat underlying anxiety, depression, whatever else it may be. So my understanding and my frustration is that it seems like there's nothing that we can do targeted at minimizing future episodes of these seizure-like episodes. Is there anything that you're privy to in terms of what we can actually do for the patients?
Well, I think one of the most important things is convincing the patient, the family, and even the other medical providers that this is a legitimate condition, that this person is not faking it. They're not just doing this to get attention. They're truly suffering, and they're not, who would really choose to necessarily be this person that's thrashing out in nature? We have to view that patient as someone who's suffering. And this was actually one of the first experiences that I have had as a physician. I'm right now on a consult liaison rotation. And kind of the key word there, I guess, like liaison. And I interacted with other healthcare providers, nurses, techs, even other physicians, I must be honest about, who are like, oh, that person's just faking it. They're full of it. And it's like, no, like that person is, perhaps this is related to an unconscious stimuli, something that they can't control that's like causing this trigger. Maybe that this is actually a panic attack that this person is having. This person had a severe episode of tachycardia. Maybe it's actually just a severe panic attack that's causing these abnormal movements. This person is suffering, and we need to offer treatment to this person. And I think that is one of the most powerful things that we can do.
Yeah, I think a lot of the times, especially from the perspective of nursing staff, or maybe even the primary team, the internal medicine doctors that are taking care of these patients, there can be some level of frustration, because whenever a person has these episodes that are seizure-like, it has to be taken very seriously. Usually, at the very least, the nurse or whoever witnesses this kind of episode is reaching out to the primary internal medicine doctor who's taking care of the patient. And many times we just call the code. There's a rapid response saying that this person needs emergent intervention right away. And the neurology team comes. A lot of individuals comes. The rapid response team is composed of, nursing staff, residents. We've certainly served on many RRTs and responded to a bunch of them. And these are people that aren't sitting around just waiting for the code to go off, but they have their own, at least in our case, when we were residents, part of the RRT team, we had our own caseloads, and whenever the alert went off on the loudspeakers, we had to drop everything we're doing, and we have to attend to, to this emergency that the code is being called for. And I think sometimes, although it is very unfortunate, in the course of a busy day, people can get frustrated, and perhaps that's where some of this notion, that they're saying that they might be faking it, maybe it's coming from that kind of frustration, because I think everybody, even in the midst of those frustrations, really wants to take care of patients. We're in this profession because we want to help other people. And, we're certainly none of us have gotten into this job certainly to minimize complaints of other people. So perhaps, I'm just going to chalk it up to some of the frustrations with the hospital system, the heavy workload that especially our nursing staff faces at many of our hospitals. And, on that note, that is something that we are very conscious of as psychiatrists as well. For example, psychogenic non-epileptic seizure used to be called a pseudo-seizure, but that term has been phased out because, there's obviously associated stigma with it. It's pseudo, like fake seizure. It literally says fake seizure. So we are taking more of the approach, and rightly so. Whenever I have a patient who's of concern for having PNES, we always make sure that we tell them, hey, we're not saying that you didn't have a seizure. You did have a seizure, like we all witnessed it, but the origin of your seizure isn't where we would typically associate with that, like you talked about, what we see on the EEGs that we do. This is coming from a different place, but that doesn't mean that you didn't have a legitimate seizure. We all saw it. we are validating your concerns, and we're here to help you through this event.
Right. And it's interesting you say that. The lecture that I listened to that I referenced earlier, that YouTube lecture, is saying that we also really do need to distinguish this from traditional seizure, because these psychogenic non-epileptic seizures cannot lead to brain damage, at least as we understand them now, whereas traditional seizures can. Traditional seizures, of course, those people need to be potentially even intubated. They need to go to the hospital right away. But psychogenic non-epileptic seizures do not cause brain damage, is at least what he was talking about.
And no concern for respiratory cessation, right?
That's, at least, look, his words, not mine. Don't shoot the messenger. But, but like I said, you also, sometimes people with psychogenic non-epileptic seizures also do live with epilepsy. It's not mutually exclusive.
I've seen patients
it's
like that,
extremely challenging to make this diagnosis. And unfortunately, the prognosis isn't amazing either. Some of the data I'm looking in front of me, there was one study that said that only 16% of people no longer had seizures 6 months after receiving their diagnosis. 16%. And then this other study in 2013 showed that between 66 to 87% of individuals with PNES, PNES, continue to experience them. So unfortunately, it seems like these people are not getting adequate treatment. It really makes me sad, and that's why I wanted to do this episode today. When I was even trying to help this family learn about this condition, I went on YouTube, Instagram, the regular social media. There wasn't that much stuff about this. If you type in something like, diabetes, I get that's, of course, way more common, but there is such a plethora of information. What was it? Between 2 and 33 people per 100,000 lives with this condition. This is very, very common. And like I said, more women live with this, especially women who have experienced potentially trauma or anxiety in the past. Now we look at kind of what's going on in our society today. We're seeing more and more females in particular self-cutting, having to deal with body image issues. Maybe that's related to their social media use, but ipso facto, perhaps that we're going to see also more cases of psychogenic non-epileptic seizures in the past too. And us psych residents and us really healthcare as a whole need to offer better care to these individuals.
I can definitely see the reason for concern there. Is there anything that we can actually do besides providing support, providing education? Because as far as I know, we're very limited, and therapy is the only real answer.
Right. I kind of look at it as, we faced some significant dilemmas in this situation too, right? Does this person potentially go to a mental health facility? Do they just engage with outpatient-based care? Do they deal with an intensive outpatient program? All of them seemed like reasonable options, and all of them seemed like kind of shitty options at the same time. What I kind of envision potentially our future's career looking like is more specialized care. What if this person could go home and engage with psychogenic non-epileptic seizures support groups that were available through telemedicine? Have them meet other individuals that live with this same condition. I think that's the solution to really solving this. One of my biggest therapeutic values of my bipolar disorder is when I started actually attending bipolar disorder support groups. And bipolar disorder support groups, it's bipolar disorder is more common than this. They estimate roughly 4% of the world lives with bipolar disorder. They think so. Way, way, way more common. I get that. But maybe that's why we need to build these kind of telemedicine-based support groups, Zoom support groups for this, because I think there's such therapeutic value in finding a community.
Right. And anything that we can do helps, right? Because it is a fact that there's a lot of people whose lives are significantly impaired by psychogenic non-epileptic seizures. Just thinking back, I remember I was taking care of somebody. This is somebody that I was seeing on an outpatient basis. And he's been having so many of these seizure-like episodes that he literally couldn't leave the house anymore. He said whenever he goes to the hospital, especially to the emergency department for some reason, he would kind of get overwhelmed and have one of these episodes.
Right.
And it got to a point where he literally didn't want to leave the house anymore. He said, I'm just too scared.
Yeah.
And what is the answer here? At least if it was an organic seizure with associated waveform changes on EEG, we have a better answer for that, right? We know, get an anti-epileptic on board, and hopefully keep them from having another episode in the future.
Mhm.
But for something like psychogenic non-epileptic seizures, like what is the correct answer? Just support groups? That seems like, I don't know, if I was that patient who couldn't leave my house because I was so terrified that this was going to happen, and I'm experiencing it to the degree where I'm literally collapsing on the floor the minute I step into a hospital because I'm so overwhelmed. I can't even remember what happened. And if I'm told that I need to just attend therapy, it seems like an inadequate solution to me. So I think that just speaks to the fact that, this is something that we don't have all the answers to yet.
Yeah.
And that's the truth with many aspects of psychiatry. There's so many disorders that we see on a daily basis where we wish that we could do more for the patients, but the reality is we're limited in the tools that we have. And in essence, right, psychiatry is considered the last frontier of medicine. This is a field where we're continuing to make new innovations, continuing to look at issues that need more answers. And perhaps this is one of them.
So, I remember you mentioned you are potentially interested in consult liaison psychiatry. At one point you've mentioned
Possibly.
this. Possibly. So I would want to see you put your liaison hat on for a second. Let's imagine that, I'm an internal med physician and I'm managing this patient. I'm about to bring you on as a consultant, and, you hear me say like, oh, this patient's, full of shit. They're faking it. Like, how would you try to best advise one of your fellow physician colleagues?
That's a difficult question because, the easy answer here would be to, of course, say, hey, no, that's not right. This isn't fake. This isn't, something that this person is just doing on a whim. This is a real issue that's going on, that's having significant impact. But at the same time, that's the liaison part of the consult liaison role, right? We have to be able to maintain camaraderie with our colleagues. And there's a chance that for somebody who doesn't see this on a regular basis, because to be honest, like as a psychiatrist, it's not something that I see on a regular basis. Yes, we do see it from time to time, but it certainly isn't like bread and butter. I'm not seeing it every single day. So perhaps to somebody who isn't as familiar, perhaps to somebody who's going through the frustration of having a high patient load, maybe they're on day 7 out of a 7-day shift, maybe they have some issues going on at home, maybe out of that frustration, they can say, falsely that this patient is faking it. This person is just trying to give me a hard time. So in that sense, it's a very difficult question to answer. I think how I would handle that situation is I would just take what he said at face value. I would just interpret that as, okay, this person may be having a PNES episode, and I'll just go ahead and do my thing and just write my recommendations and leave it at that. And perhaps on another day, I can kind of, provide that education to that provider who brought me onto the case. But I think, in a real world setting, I will probably try to provide that education within my recommendations that I leave in my note.
Yeah. You're a kinder man than me.
Now I'm just scared of confrontation.
Well, because here's what I said. I ran into this situation and I put on my, I think, Sigmund Freud hat for a second. I certainly got the beard now going for a little bit. Shout out to the video podcast. Check out the video podcast. And I was like, hey, it kind of sounds like your ego's getting in your way of this diagnosis in a sense, or you're maybe in perhaps of the treatment. Us doctors, we like being able to solve problems and help situations. When in reality, like, there's some situations that we can't perfectly influence. There's some treatment modalities that when we implement them, they're not perfectly going to fix things. It's not going to be quick. It's going to be very complicated and take a really long time. And so I said, look, you kind of have to check your ego at the door here and realize that this person is doing this perhaps unconsciously.
Did you really say that?
Yeah.
That was very brave. Was this an attending or another resident?
This was another resident.
Okay.
I would say it's
still very brave.
I would have to say it to an attending perhaps at this point too, because it's like,
hey, maybe in a few years.
No, I'm going to send it, man. I think we have a particular skill set that we like dealing with the nebulous, right? And I think a lot of other healthcare, it's look, I have blood pressure at this level. I give this dose. Okay, it should come down. This is the understanding, this kind of left brain statistical analytical side of medicine. Whereas us, we really specialize in the right side, the nebulous, well, hey, look, I'll tell you what I did on this case. I switched this person. They weren't doing that well on Prozac. We wanted to try something different, so we tried Zoloft, which has an FDA indication for PTSD. Is it going to perfectly help? I don't know. Maybe. They could let me know in 4 weeks. We also even titrated her on propranolol, trying to target some of that generalized anxiety, and we thought that potentially some of these movement episodes were precipitated by her kind of noticing some of these palpitations in her heart and starting to get a little bit anxious before these things coming on. And in a sense, by using propranolol, maybe can help out with that. Is it going to perfectly prevent that next movement episode that she has? I hope so, but I don't know. I need to be realistic in nature too. And, it really was a fun educational experience for me putting on that liaison hat because, it's like you said, it's so challenging being an internal med physician. I'm so glad we chose psychiatry.
Those guys work hard.
They work really hard. Yeah. But it is such a different approach to this situation because it is so much more nebulous in nature, and realizing that we're not going to be able to perfectly solve all healthcare problems, medical problems.
Right. And that's the art of psychiatry, right? Mm-hmm. Like you said, internal medicine and a lot of other specialties, they have imaging that they can look at. They have objective and very definitive lab values that they can look at, and they can just point to that and kind of come up with a diagnosis regardless of what the patient is subjectively reporting. Mm-hmm. However, in the world of psychiatry, I mean, if we really think about it, how we elicit a diagnosis, how we come up with a treatment plan is based on oftentimes a patient's subjective interpretation of how they're feeling, mm-hmm. and then our own interpretation of what the patient's account of how they're feeling is. Mm-hmm. So there's a lot of room for, things to get missed, things to be misunderstood. And that's just one of the challenges that's inherent to the world of psychiatry. But it's, a field that we love. It's a field that we are dedicating our lives to. And, it's one of the challenges that comes with the field, but we welcome it. And, the best we can do is keep reading, stay educated, and just try to be as empathetic as possible. And, ultimately take action on behalf of the patient, even if you don't feel like you have the right answer or you don't have 100% foolproof solution, rather, do something. And I think in this case, you did exactly that. And you also advocated for your patients a lot better than I would have had.
Yeah,
kudos to you. You're a very brave man.
Thank you, sir. And, I think we're being, I guess, a little pessimistic right towards the end of this episode. So if you're listening and you have a patient, maybe if you're in the healthcare field like us, or if you have a loved one, or maybe if you're that person that lives with psychogenic nonepileptic seizures, I think first and foremost, realize that the healthcare system takes you serious. This is a real condition. This is a real condition. And, I remember this patient, she said to me numerous times, everyone comes in this room and tells me I'm faking it. It's you're not faking it. And it was so hurtful. I hope the people who are watching this video podcast see your face. It was so hurtful to hear her say that. It must imagine the pain that this person's in. And I think optimal care is following up closely with a neurologist, with a psychiatrist, and with therapy in some regard, and addressing perhaps potential trauma or anxiety or personality, potential disorder issues that you're dealing with, all of which are very, very challenging to navigate. So I think it needs to be a team approach to treat psychogenic non-epileptic seizures.
Yeah, I must have misunderstood you before, because I had just thought that between the treating teams, they were kind of suggesting that it might have been fake. I did not realize that the patient was actually told to her face that she's faking it. And if that's the case, that's totally inappropriate. Yeah, that should not be tolerated. And perhaps, one of our jobs as psychiatrists, especially when we're on our rotations within the hospital setting, is to provide more of an education to other staff members.
Right.
Perhaps that's a major way we can make a difference for our patients' well-being.
Exactly. And that being said, it's who knows exactly what was said to the patient, right? Did someone explicitly say you're faking it, or did they say it in a different way, but how that person interpreted what that person was saying is, oh, so they're telling me I'm faking it.
Right.
So who really knows? But I think the more that hospital staff and everyone from, patient technicians to the cafeteria staff to even the janitors to, of course, all the direct medical care providers are just aware that this is a real condition and that this person is suffering, the better we can help this person.
Because it's all about teamwork at the end of the day, right? That's the way that we can ensure that patients have the best possible outcome. And when I say a team-oriented approach, I mean, I'm including the patient in that. Because
Absolutely.
It's important. What they tell us is important. That they feel that they're validated, that they feel that they're being, listened to on a genuine level. So it's, everybody's in it together.
Right.
And
Absolutely.
I think maybe we can end with that on a positive note.
Hey, if you guys made it to minute 35, leave a 5-star review. Thank you for checking us out. Check out my podcast, Talk Mental Health with Dr. Logan Noone. Dr. Tony Lee came on. He's a great neurologist, great friend. Cheers. Thank you.